All right, welcome. This is Pelvic Health Essentials. This is our first week, so I want to welcome you all. If you're live or watching the recording, thank you so much for being here. And I wanted to give some input on how to get the most out of this course before we dive in. So really my goals for these 6 weeks is that you're walking away from this course having a good working knowledge of how your day-to-day can impact your pelvic health, so that you're starting to have these little thoughts arise where you're like, oh, I could do this instead of this, and it would help my pelvic floor, or it would help my pelvic health overall. And I think when you have the knowledge, then those things start to happen. My goal is not for you to feel like you're having to follow this specific regimen, but rather learning how to integrate things into your day to day. So that incorporates having the skills to both maintain pelvic health, but also be able to identify early, hopefully very early on, if things are starting to be out of balance or not quite right. And ways like the first initial steps to start improving that symptom that's arising. Instead of what commonly happens is moms are like, oh, well, this must be kind of normal. And they ignore it for a little bit, or they manage it the best they can. And then it's all of a sudden it's 6 months later and this problem is increasing, or it's just not going away. And now they haven't received care as early on, when there could have been a few simple things they could have done right away to help out. And also just generally improve confidence, that you feel more able to protect and restore your body in postpartum. All right, so how to get the most out of this? Really just making sure you watch these videos or participate live in the education sessions. I mean, that's the meat of this course. And each week is to some degree building off of the previous week. So I do think it's important to go through it sequentially, even if you're watching the recordings. I wouldn't skip around on watching the recordings. The Facebook group, I hope you all will log in. Let me know if you're having trouble getting in. It is a private group. I did send you the link. I think you can request to join. If you have any issues with that, be in touch with me. But this is really where I think we're going to get everything coming to life, in terms of you asking questions or sharing you're like not understanding a concept, or you're having a challenge incorporating something into your day to day, or wanting more personalized tips and tricks on how to do that. And then I'll be taking deeper dives into topics that seem to be of interest, or requiring a little more explanation. And you don't need to be super active in the group, but I think popping in a couple of times a week, once or twice a week, would be really helpful for your learning, whether you're very active in posting or just kind of watching from the sidelines. Whatever works for your learning is good. The group coaching sessions. This is also where things start to really come to life, because it's where I'm going to be asking really what I would call powerful questions to get you thinking about, how am I going to incorporate this in? How can I set some strategies if I'm still pregnant? What can I do right now? What's the plan right now that I am in postpartum? What can I do? And we'll be using live examples. So I think those are probably the most important things to attend live. And then the one-on-one coaching sessions, I think ideally I would say towards the end of July, when we have a few, especially the first 3 sessions under your belt. So you're already hopefully incorporating some of these things I'm suggesting, and we can take a more personalized, deeper dive in that 30-minute call, especially going into some things that you may not want to share more openly in the group. And then giving me feedback along the way, because I'm willing to kind of pivot and adjust as necessary to improve your learning. Most of the education sessions are not going to shift too much, but what I provide within the Facebook group will really change depending on feedback. So if you want more of something, let me know. If you're curious about a topic that I haven't even mentioned and you're hoping I would, let me know. All right. So just a disclaimer, I want to be very clear that this is purely educational information. Nothing in this course should be taken as medical advice. However, it may raise a lot of thoughts or ideas of what you might want to talk further with medical providers. So that is there for your information. This is educational. I am not a medical level provider. I'm an occupational therapist. I cannot diagnose. I cannot treat through this platform either. So if I feel that we're crossing that line, I will let you know with your questions, what I can answer and what I cannot. Okay. All right, let's dive in. So this week is Pelvic Health 101. Really what is, I think, essential to start this course off is that we all come to the table and have a good, thorough understanding of what do I mean by pelvic health. So I'm going to be tossing out some textbook definitions today, but more so giving you my viewpoint on how I define it and how I work with clients on understanding their pelvic health better. So I think if you can share in the Facebook group, if you're not live, or write in the chat, just kind of what comes to mind when I say pelvic health. What brought you to this course? You must have some level of interest in pelvic health, and that could be insightful for me to know. And I'm also always really curious if you've ever actually had a conversation with a medical provider about your pelvic health or pelvic floor, or inquired about pelvic floor therapy, and kind of how that conversation went. I always find that information interesting because it really runs a full gamut from providers being like, oh no, you're fine, to it being a very in-depth and informative conversation. All right, so let's first start with some common myths about pelvic health, pelvic floor. Oftentimes when I say, what is pelvic health? Women immediately mention Kegels. And Kegels is a portion, a tiny portion of pelvic health. It's an exercise within the realm of pelvic health, but it is not everything by any means. And we will be talking about Kegels a bit next week. But it is a lot more than that. That would be like doing a full body exercise, wanting to learn about full body exercise routine in the gym, and then just showing you a bicep curl. So there's so much more to it. Leaking is a common myth, especially around pregnancy and postpartum. Moms being like, oh, it's just normal. Well, it's not. And you may be aware of that, you may not. But we're going to be talking about that a lot as well. So pelvic floor isolation, this may be like, what are you talking about here? But a lot of times people think, oh, like I have an issue with leaking, or I have some pelvic health problem. It's just my pelvic floor. Pelvis is a very central part of our body, and it impacts or is impacted by many other areas in our body. So treating just the specific problem or pain point in the pelvic floor often does not go far enough into truly resolving the issue. And you'll, I think, learn a lot more about that today. And then breathing. Sometimes when I incorporate breathing into my treatments, moms will be like, well, why are we doing breathing? And this is, we're going to have next week is almost the whole session about how you're breathing. And breathing involves pressures in your body, and they're intimately related to the pelvic floor and your pelvic floor functioning. So not doing breathing exercises or breathing awareness in pelvic floor therapy or pelvic health education is really missing a big aspect of pelvic health. All right, so this is a definition from this book called Below Your Belt. I'm a huge fan of this book for women of any age. It's actually geared towards young adolescent girls in educating them about their pelvic health, from bladder function, bowel function, vaginal health, uterine health, sexual health, and the pelvic floor, which is the muscles and structures. This is their Missy Lavender's definition of what pelvic health is. Pelvic health pertains to all parts of the body below the belt and includes bladder and bowel, vaginal health, uterine health, sexual health, and muscles and structures. I take it a little further though in describing it. So let me jump actually down to the bottom. You may hear these terms pelvic health and pelvic floor. So the pelvic floor is part of pelvic health. When I am conducting or acting as a pelvic floor therapist in one-on-one sessions, I don't call myself a pelvic floor therapist very often. I do sometimes just for understanding's sake, but I really view myself as a pelvic health therapist because if I was only treating, if you look at the bottom, the bones, connective tissue, ligaments, nerves, and the muscles that serve the functions of elimination, intimacy, and organ protection, I would not always be helping my clients. Sometimes all of the pelvic floor can be functioning pretty good, yet there is still pelvic health dysfunction that can benefit from therapy. So let's back up and go, okay, well, what is pelvic health? It's the health of every structure in the pelvic region, not just that connective tissue, bones, ligaments, muscles. And also, pelvic health is not just physical. It includes emotional, mental, spiritual, social, environmental factors of health. So I come from a perspective, and it's very much rooted in my training as an occupational therapist, that all of health is very holistic, that we can be in good physical health in any area of our body, yet still not be in optimal health. So the same applies for pelvic health. Sometimes the physical aspects are pretty good, but there is trauma or there is nervous system dysregulation that is impacting the pelvic floor or the pelvic health. So if you have any questions about that, please bring that over to the Facebook group. I think this is a really important concept to think about. I want you thinking broader than just your physical structures in your pelvis. I want you thinking about, how does my emotional state, my mental state, my spiritual state, social, relationships, environment impact this? Because it all has influence on it. All right, so this is my own little coming together of what I think are the elements of optimal pelvic health. Starting with the more physical portion, strength and flexibility. We need muscles, and there's 14 of them in the pelvic floor that are both strong and flexible or pliable, meaning they can hold, but they can also completely relax. We'll talk about that a little bit more later, but often when I'm seeing women who are referred to me for pelvic floor dysfunction where they are strong, but they're unable to relax. I think that's more of the problem. Not always, but generally women are really concerned about, oh, my pelvic floor is really weak. But in actuality, their pelvic floor is actually overly stiff and tight and just tense, which comes to a surprise to them. So muscle balance. There's a lot of structures. Now, my pelvic model is not perfectly organized in terms of the structures, but there's your reproductive system, your bowel, and your bladder, and it's all tucked in very tight into this bowl-like shape. And we are built and held together by having equal and opposite forces and pressures. And this is an area, if you think of all the stuff that's above our pelvis, I mean, it's our whole upper body, it's our head, it's our brain, it's our spine, all the organs, and gravity is pushing down on that. And then you have pregnancy and all those forces shift. And then you have birth and there's a lot of more forces and shifts and pressures. That things can get knocked off balance. Things can be tight and be pulling. And that creates an imbalance within the pelvic floor that pelvic floor therapy can be really helpful. All right, breath and relaxation. I've already mentioned it, and we'll come back to it probably every week, but the ability to connect your breath to your pelvic floor to promote relaxation and awareness. It's an area of our body that for a lot of people is slightly mysterious or completely mysterious. We can't see it that well. What's going on down there often? There's a lot of different sensations that can run the gamut from ecstatically pleasurable to horribly painful and scary, and we don't understand what's going on. So building awareness through practice with the breath is really helpful and leads up to this one in you feeling more comfortable and also knowledgeable about what's happening and what's going on. So everything kind of links together here. So back up to the comfort one, feeling comfortable when talking about your pelvic health. I think it's important to have the words you need to describe what's going on, knowing that I think it's in my labia, I think it's up in my uterus, and that could be a guess. I think it's back in my bowel. Where are these sensations coming from? And do you feel comfortable enough to mention them and talk about them? So kind of breaking away that embarrassment that may come with it, or just the fear or shame about talking about a dysfunction or a problem in this area is really the most important first step to healing it and improving something that's not right. And then knowledge, I think all women should have a basic functional or familiarity with the basic functions of the pelvic region. And we'll get into that today. We've already mentioned some of those. And then add on another layer, knowing a little bit about what you can do to positively impact that. I think this course will offer you more than a little bit, but knowing at least the first steps in terms of recognizing, this isn't normal. That's really great and important, and will get you treatment earlier, whether it's from things that you're doing that you may learn in this course, or to reach out to a professional. And then this comes back to that social and kind of environmental impact on pelvic health. I've found, and there's lots of research on this, that women who are in more abusive, whether it be sexually abusive or emotionally, however, financially abusive situations, have a higher incidence of pelvic floor dysfunction. And it's especially true when it's with the sexual relationship. So safe, trusting relationship with that partners is really important for your overall pelvic health. Okay. All right, so this is my own visual of your external anatomy. So this is your female genitalia, and knowing what the structures are or are correctly called. A lot of times women are just calling this their vagina. And this is not your vagina. Your vagina is actually inside. There's nothing external except the opening. So I think it's really important to give you more words for describing what you might be noticing. And you're more likely to notice things more externally than internally. Anything internal in our bodies is not patient level knowledge, it's provider level knowledge. And if there's something more internal going on, it usually is an indication to see a provider. External, oftentimes just having knowledge and knowing like, I'm more red on my labia majora, what should I do? And I'm not going to go through a lot of things for the external genitalia, but I think it's a really important step to have the words to describe what's going on to a provider. So I'm just going to take you through this. So this is an image, if you're totally confused by this image, this is a left leg, a right leg going up. This woman is lying on the table to get a pap smear. Okay, so this is the top front of, and it's called your mons pubis. It's that fatty cushioning over your pubic bone. And if we drop down, the bigger outer lips are called your labia majora. The inner, smaller or more irregularly shaped lips are your labia minora. A lot of variation with how we appear from person to person in the labia, majora and minora. And then you have your vaginal opening. The perineum is the space between the vaginal opening and the anus. This is the area where it's most common that a perineal tear would occur during childbirth, although it can occur in any direction. It's just most common in this direction. And then your anus in the back. Your urethra is where your urine comes out. It's often a very small opening and sometimes very hard to identify. Sometimes it pops out a little, sometimes it's more internal. Everyone's a little different. And then above that is the clitoris and the clitoral hood. I think it's really important. The term vulva is often not understood. Women might think, well, what's the labia? What's the vulva? How are they related? Well, a vulva is kind of a catch-all term for the external female genitalia. So when you're pregnant and you get an ultrasound to identify the sex of your baby, what they're looking for is a penis or a vulva. Okay, so the vulva is defined as the labia majora, labia minora, vaginal opening, and clitoris. So all in one. So external female genitalia is the vulva. And then there's different parts to that. So I recommend, and if you participated in my 5-day pelvic health challenge, the last day was to do a vulvar self-assessment and just looking at these areas and being more familiarized with what you look like down there, and doing this a couple times a year to see if there's any changes occurring, the health of the skin, all that. I will post that video into the Facebook group. Okay, so 3 main functions of the pelvic floor. So the pelvic floor muscles are integral to essential bodily functions. Elimination, the ability to hold, release, and not have leaks with urine, stool, and gas. So very common that this will occur. This is a pretty, especially around pregnancy and postpartum, leaking of urine and or gas is very common. And what can you do about it? That's what we're gonna go over in week 3. Intimacy. This is week 6. We're gonna get into more detail here. The ability to engage in pain-free, very key, pain-free sexual activity and achieve orgasm. So it's the ability to achieve orgasm. It's not the ability to achieve orgasm every single time. That's not a requirement for optimal pelvic health as it relates to intimacy, but it's that you can achieve it from time to time. Organ protection. So this is going to be sprinkled in throughout this course. But our pelvic floor, let me just remove the organ contents, but pelvic floor muscles, if these were not here and we were standing, like what would happen? I mean, our insides would literally fall out of us. These are our hip bones, nothing would be here. And it's an essential, very essential muscle group that both protects and provides kind of this buoyant support. So if you're overly tight and rigid, it's like jumping on cement instead of jumping on a trampoline, much more uncomfortable. So we need a flexibility and pliability to our pelvic floor for optimal organ protection and comfort. And it needs to be strong enough that it's holding things where they need to be. Pretty complex system here. All right, so this, I want clients to understand, especially when we're looking at the prevention side of things, to think of pelvic health as it relates to your quality of life. So that last slide, those are very basic, essential aspects of life and certainly quality of life. If we're not able to conduct our toileting needs, sexual activity, and organ protection to a certain level of satisfaction, quality of life goes out the window. If you need to organize your day around toileting, there's a lot of restrictions on what you can do. So just remember, this is why my thing is about prevention of pelvic floor dysfunction so that you don't ever have that impacting your quality of life, which relates to relationships, daily activities, ability to work, ability to be the best mom you want to be. It just spirals so quickly when some of these basic functions are not operating optimally. And then there's this other kind of vow of secrecy. Like, these are not things that we talk about openly and publicly. You sprain your ankle, everyone can see it. People give you advice, whether it be good or bad. People say, oh, I hope you get better quick. If you have chronic pelvic pain, you're probably not talking about it. Or if you're always leaking, there's more of this embarrassment and shame that sets into spiraling, not getting care, trying to just hide it and manage it on your own. And oh, it's no big deal. Everyone has this. And the longer a problem persists, the harder it is to heal and fully return to optimal functioning. This is why I'm so happy that you are here. You're really taking that great first step in receiving the education you need to best impact your own pelvic health. And this is a course that I wish went right along with childbirth education because it's that essential for women and their own healing in postpartum, which we do not talk about enough. Okay, so pelvic health in your childbearing years. So this is giving you kind of my view of what would be optimal pelvic health when you're pregnant and then in postpartum. So optimally, you're entering or leading into your labor and delivery with a balanced and aligned pelvis and pelvic floor. And this will better your chance of an quote unquote, whatever you view as an easy labor. I think everyone's view of that is very different. So I'm not gonna put parameters around what that is. But when there's balance in the muscles, everything's aligned well, and the pelvis is aligned as well as it can be. Remember, everything's loose, it doesn't like to stay. It's very likely that you're gonna have that baby's gonna have just an easier time coming out. So my ideal scenario is a combination of both pelvic floor therapy and chiropractic care in pregnancy to prepare you for birth. And chiropractic care from a chiropractor who is Webster trained or has lots of training in treating pregnant women, not just any chiropractor. They need to really specialize in pregnancy. And then in postpartum, it's more about the knowledge so that if something arises, you can respond right away. The sooner you respond, the better the outcome. So you start leaking, you know what to do instead of just putting a pad on. There's so much more you can do to impact that. And that's going to be week 3, where we really get into how do you, in what occupational therapists call self-manage symptoms that are not desirable. And also, I think there needs to be an understanding of when you need to start doing this. We need to give our body a lot of grace and some time to rest and do its own healing before we start messing with it in postpartum. So a lot of what I recommend is not starting like day 1. Baby came out, okay, start repairing your pelvic floor. Our bodies will do a lot of it for us, but it's as you get into 6 weeks, 12 weeks, 6 months, are things not going back into place? What can you do? All right, so how do I know if I'm in optimal pelvic health? So there's really 3 ways to screen this for yourself before reaching out to a pelvic floor therapist. I'm going to post later today on the Facebook page a questionnaire that I've offered on my website before that just helps lead you to a recommendation of maybe something's going on And a course like this might be helpful, or, ooh, there's a lot going on. You probably should call a pelvic floor therapist now. Or, hey, you're looking pretty good. But those are not always like the end all be all. They're just like those magazine questionnaires, take them with a grain of salt. It's not a diagnosis, it's not an assessment. So take those with a grain of salt, even the one I post. I think it's more important to watch out for these other things. So symptom check, it's just, are symptoms arising or not going away pretty quickly in that first week postpartum for sure? Or if in pregnancy, are they disappearing at all? And they're not going away. So something's happening. And if you can respond to that right away, likely it won't turn into a significant problem, or the degree of problem it's going to become is minimized because right away you were on it and doing good things. Coming from a pelvic floor therapist, this is what this course is about. Like, if you start having leaks, that you know what to do if it doesn't improve in a couple of days. So leaking is a big one. Frequency, this means urinary frequency or even stool frequency. Like, that's a little different. It's mostly urinary frequency. I would retract that stool frequency statement. And that relates more to chronic constipation. So urinary frequency going a lot more often than you used to. We all know that could be signs of a UTI, which is something I will go into in week 3 as well. Chronic UTIs is a sign of pelvic floor dysfunction and pelvic health imbalance. But just urinary frequency, if it's not going away, it's not a UTI, why are you doing it? What's happening? Chronic constipation, talk about that a little later today, introduce that. Heaviness, pressure, the sense that something's falling out. Pain that is not improving quickly, meaning in a couple of days, it's still coming back or it's still present. Numbness, tingling, change in sensation. All right, function checks. This is the gold standard for me. Once you have a symptom, okay, is it impacting things? Are you starting to avoid activities that you used to do? Are you changing how you do things, like how you lift up your baby or how you go to the bathroom? Have you changed something because of a symptom? Needing to overplan, more stress and anxiety and doing things that you used to like not bat an eye at, decreased motivation and interest. Now, as I go through those things, you might be thinking, well, isn't that like depression? It could be. Certainly, we all are aware of postpartum depression and anxiety as being a very real reality for many moms. But sometimes it can be this pelvic floor issue that is causing the symptoms, causing this change in function, that then leads or is a significant factor into the mood changes. Or it can flow the other way as well. So I'm not discounting that this is only because of pelvic floor issues. There's many factors, but it's something significant. Anytime function starts to change, we want medical and or occupational therapy involved to help you unravel what's going on. Okay. All right. So this is a very full slide, but what does optimal pelvic health look like? So if you could check off and be like, I got that. This is kind of my goal for the end of the 6 weeks together, that you are pretty close to this or have a path laid out to get here. If you're here today, you're doing pretty darn good. And I hope I have some things to offer, but I don't know. So you have good understanding and ability to both contract and relax your pelvic floor, hips, glutes, or your butt, and abdominals. You have good awareness of your pelvic floor and its current state of tension or relaxation at any moment in time that you do a mental check-in. Can you tell? Am I tight? Am I relaxed? You never or very rarely, like less than once a month, feel pulling, pressure, tightness, pain, tingling, tearing, aching, or any other unfamiliar sensation in your pelvic region. You're able to exercise or engage in physical activity to your desired intensity without limitation. You're able to and regularly enjoy engaging in sexual activity and can achieve orgasm. You have good toileting habits and are never constrained by them. You're comfortable talking about your pelvic health with close friends, family, or medical providers. You regularly engage in a relaxation routine, even as a postpartum mom, such as meditation, but that it doesn't have to be meditation. It could be taking deep breaths or prayer. It could be a million different things. We'll talk about that a lot more. So if you can really say to all these, chances are you're doing pretty good. All right, so this is the last section for today. This is an introduction into all the conditions or symptoms that we're going to talk about in week 3, where I'm going to be teaching you ways to self-manage them and ways to take action on improving them on your own. While you may be seeking out more assistance, or even before you seek out assistance to see, oh, this isn't that major. Let me try these things Hillary taught me and see if it goes away. And actually, I must say, in a lot of cases, a lot of my clients, these are the things I teach them in the first session or two. And I had a client recently who was seeing me for incontinence, and this is all I really did was teach her a few habit-based things, and her incontinence drastically improved in 1 week. She was going from having 2 or 3 leaks a day to having 2 leaks a week in 1 week, and that progress remained. So I'm just introducing today the conditions, and we'll talk about what we do in week 3. So incontinence, of course. There are several types of incontinence. These are the urinary incontinence types. There is, of course, fecal incontinence, that is leaking of stool. That is more related to certain health conditions like IBS or colitis, as well as perineal tears during birth, particularly a stage 4 tear. But urinary incontinence, the most common is stress. This is when you leak when you sneeze, or you leak when you jump, or you leak when you lift up your baby. It's just there's an increased pressure placed on the bladder, overpowering the sphincter, or the muscles that hold the urethra closed, causing leaking. It can be a drip, or it can be a complete emptying of your bladder. Either is still considered incontinence because no leaking is normal. There are degrees of leaking though. So a lot of moms, I think like, oh, I just dripped. It's just a few drops, no big deal. I say monitor that and take some action to start improving that. Don't let that not be a big deal, because that few drips over time can turn into a lot of drips, to full big leaks, to wetting your clothes and embarrassing situations. And also the bladder is a very bossy organ. We'll get into this more in week 3, but it oftentimes can start taking over your life if you let it. So we want to get control of it pretty quick and put it in its place, being like, you are not the brain, you are the bladder. The brain tells you what's up, okay? And this really links to urge incontinence, which is actually the type of incontinence I had since I was a child and didn't really know it. And I hid it for years. And, it would ebb and flow. What I came to learn is it ebbs and flows with stress and anxiety and things. When more stress going on, you're more likely to leak. So it's very different than stress incontinence. It's a leakage caused by strong, uncontrollable urge to immediately urinate, and it's usually linked with certain triggers. So common ones like getting up to walk to the bathroom, like you just have a little urge, like, oh, maybe I have to go to the bathroom. And then you're on the way there and your bladder just does not hold. Or you're opening the door, arriving home at the end of the day, the whole car ride home you were fine, and all of a sudden you're like, oh my God, level 10 emergency, I have to pee out of the blue. someone turns on water, you didn't have to pee 2 seconds ago, and all of a sudden you hear that water and you leak. And stress and worry, the mental component, is really important with treating urge incontinence. And the mixed incontinence is just having symptoms of both. However, generally there's a dominant problem. All right, let's keep going. Chronic constipation. So this is really, I've mentioned constipation several times before, and people think like, why is that a pelvic floor dysfunction? It's a symptom or a problem that very often can impact pelvic floor and cause further dysfunction, which is why it needs to be managed. And it needs to be managed in, like, as well as it possibly can, as soon as it can. So I do not like the WebMD definition for this. Defined by WebMD as passing stool less than 3 times a week for 3 or more months. That is way too long. You should be doing something about the constipation well before then. So I define it as passing stool less than your usual amount for 1 month or more. Even as strict, I've gone as strict as 2 weeks. So within 2 weeks postpartum giving birth, you should be back to your normal passing of stool patterns. And if you're not, you're still passing stool less often, that needs to be addressed, because the backing up of stool in the rectum and descending colon puts a lot more pressure on the pelvic floor and the organs and can cause further problems to arise. So there's also something known as functional constipation, which is passing stool regularly, like every day, but the way you identify it is that the stool is never in a good, solid formed, excuse my language, but it's not in a log. It's little nuggets, I call them bunny poops, or it's loose. So it's either dehydrated, sign of constipation, or your bowel's just totally emptying and not absorbing well. So it's not a healthy bowel, and it is called functional constipation, and also should be addressed. All right, pelvic organ prolapse. So this is the pelvic floor, pelvic health issue that I think it kind of runs under the radar. Some women are very aware of it, many women are not. And it's more significant of a problem than things like perineal tears and diastasis. Those things often just get better on their own, but moms really worry about them. Pelvic organ prolapse is something that's often not on the radar for pregnant women, but is actually, and postpartum women, is actually more likely to be a significant life-impacting issue. So what is it? If you've never heard of it, it's departure from normal sensation, structure, or function experienced by the woman in reference to the position of her pelvic organs. What the heck does that mean? So your pelvic organs are arranged, I'm not going to show them in the pelvis because you can't really see, but we have your bladder. This is your vagina. I'm holding the vagina. Above it is a not pregnant uterus and very abstractly placed ovaries and fallopian tubes. Basically, they're right next to each other. In the pelvis, there is no wiggle room, and then we have the colon. And what happens if there is unequal forces or just tightness, think of like a scar, maybe pulling these organs in a little off direction. What the most common one is when the bladder hits into the vagina. So this is your vagina, this is your bladder, and all of a sudden something, maybe you have tight pelvic floor muscles on one side and that tightness, and then you're holding your hips in a funny position and it goes whoop, and so it pushes into the vagina, and that feels heavy, or you have back pain, or you are constipated, or there's pressure, there's incontinence, there's a lot of different symptoms that lead to it. What it is not, it's usually not an organ coming out of your body. It feels like that, but if you think about this, there's no way your bladder that's pushing on your vagina can come out of your vagina. It's separate, it's not. But what can happen, the one exception, is a uterine prolapse when the uterus kind of falls down through. That is much more common in older geriatric women. It is not common in childbearing aged women. So I don't want you worrying about that. Oh my God, my uterus is going to fall out of me after I give birth. Get that out of your head, okay? And that sensation that can arise is not your uterus falling out. Chances are there are 8 other types of pelvic organ prolapse other than uterine. Okay, so but it's really common. The stats around it are kind of shocking. 50% of women have some degree, now there's levels, we'll get into this more in 2 weeks. There's levels of prolapse, of how severe they are. And they are 50% of women irrelevant of age or birthing status. So they could have never had children and could be an 18-year-old soccer player, and they could have a second-degree prolapse. These studies were done on women of all ages, and it was surprising the number of young women who've never birthed or been pregnant who have prolapsed to some degree and don't even know it. And that leads us to further conversations in the medical community. Do you do anything about that? And my thought is no, if it's not causing any disruption to function or unwanted sensations, you don't do anything about it. But there's a lot of different views on that. Okay, so risk factors. Vaginal delivery, yes, it does increase your risk. After 1 birth, it increases your risk 4 times. For 2 or more births, 8.4 times. Forceps delivery, 53% increased risk of pelvic organ prolapse. But these other factors that are unrelated to childbirth, high BMI, that means high body mass index, overweight, obesity can impact. Chronic cough, chronic constipation, there's the constipation back again. Diabetes and heavy weightlifting can all contribute or add to your risk factors for getting a prolapse. Okay, diastasis recti is like all over the place now, like don't do this, do this. And my main focus here, if you haven't heard of diastasis rectus abdominis, is the official name for it, DRA, otherwise known as abdominal separation. It's separation in, so this, I like this picture because it's showing the rectus abdominis muscle. It's your 6-pack muscles. It's the most surface abdominal muscle. It's what I would call a vanity muscle. I mean, of course, that helps you to sit up, but it's more, it's not as much about deep support, which is what I focus on in my rehab. I rarely am focusing on helping moms get a 6-pack back because it's not functional. But anyways, I digress. This connective tissue in the middle is called the linea alba. And it's as you're pregnant, this is what happens to the linea alba. Eventually it's just like, whoa, it kind of gives and loses its integrity. Connective tissue is very fibrous and woven, and after so much stretching, it's just kind of like, whoa, and it just loses its tenseness. So in a study of, this is a huge study, I can post it to the Facebook group if anyone's interested, but the takeaway from it, 100% of women at their due date have a diastasis. 60%, down 40%, 6 weeks later, have it. So 40% of those women, their DRA is gone. 39% have it at 6 months. So now 61% of women who had it at their due date no longer have it. And this is with no treatment, doing nothing but carrying on with your life. But the significant factor is between 6 and 12 months, there's only that little bit of improvement. So a lot of natural healing occurs in the first 6 months. So I think this course is a key way to learn about what can you do to promote healing of your diastasis. And beyond that, don't worry about it. If you still are having symptoms that are unwanted or discomfort, or noticing that that gapping at 6 months plus, that's when you seek out more skilled services. All right. Pelvic pain. So this is a giant category of things. It has many causes, and sometimes the cause remains unknown. And the diagnosis for therapy is just simply pelvic pain. But some common medical conditions, well, not that common in terms of knowledge, is endometriosis. This is where the uterine lining is overactive and grows. Dysmenorrhea, that's painful periods. Your gal probably had a dysmenorrhea cycle, if not many. Vaginismus is tight vaginal opening. Muscles of the vagina are very tighter than they should be. Hypertonic pelvic floor. So hypertonic means a muscle is really rigid and tight and it can't relax. Very common, it's probably one of the most common things I see when I assess moms, and can co-occur with medical diagnoses. So there's hypertonic and there's hypotonic. Moms tend to be more worried about hypotonic when I challenge that I think the bigger problem is hypertonic. Pain with sex. So this and those conditions all impact sexual activity and comfort with sex. This stat is linked to postpartum women. 50% or more of women will report pain with sex in the first 6 weeks to 6 months. This is also known as dyspareunia. It has a diagnostic name. Pain with sex is dyspareunia. Cycle that away and for some trivial pursuit. And it's classified as not just pain during sex, it can be pain before, during, or after sexual activity. And sexual activity is also not classified as just penetrative sex, it's any type of sexual activity. And it's never normal. I think if you take away one thing from this slide, is knowing that you should not be having pain in your pelvis ever. And if you do, and if it's recurring, it needs to be looked at or addressed. Pain in the pelvic floor is not normal, and it's frequently resolved or improved with pelvic floor therapy, especially when it's addressed early on. Okay, quick thing, I think this is the last slide on birth scars. I'm going to run a minute or two over an hour. Oh, I guess I started 5 minutes late, so actually I'm doing good. So C-sections, of course, you're going to have a scar, lower abdominal scar, and it needs to be treated as if you had a major abdominal surgery. It's not just, oh, I had a C-section, no big deal, I just have a scar. No, that scar needs to be massaged, needs to be softened in time. You can't do it right away. It needs to do its healing first. It needs to close. But this is something that I'm really a proponent of, scar massage. I will post a video, probably not today, but in another week or so, of how to do a C-section scar massage. In Hawaii, we actually have a pretty low rate of C-sections. We are the 10th lowest in the country at 26.8% of births, and this is as of February of this year. Perineal tears. So this is when there is a tear between the vagina and the anus most often, and there's 4 stages of it. So stage 1 is only the skin, and that occurs in 9 out of 10 vaginal deliveries, first-time vaginal deliveries. So it's very common that requires absolutely no treatment. I basically would say it's anywhere from any kind of cut you get at home and don't see a doctor for. So it could be a slice with a knife, but you're like, no, that doesn't need a stitch. That would be classified as a first-degree tear. It could be a paper cut. So some midwives I've worked with when I've done births, I've called them like skid tears. It's just like the baby came out really quick and just like the skin just kind of splits a little. They heal on their own, usually no lasting impact whatsoever, despite them being very common. And they usually don't even cause a lot of pain. Second degree, so that's skin and some muscle. This is 6 out of 10 first-time births. And I think at second-time births, it's more like 30%. Don't quote me on that, but it's definitely lower. It does require stitches and can be painful, but usually has no lasting impact per research. I challenge that and say that it can, because there is going to be a scar. Depending on where that tear is, that scar can cause some issues in terms of the tissue being pliable and flexible again. Stage 3 and stage 4. So stage 3 is the skin, muscle, and anus. So basically a stage 3 tear is just all the way down. A stage 4 is all the way down and deep because it gets the sphincters. And the sphincters of the anus, the rectal sphincters, excuse me, are what hold in stool. And those are impacted in a stage 4 tear. Now you see the 3 out of 100 in the statistics, they always combine stage 3 and 4 together. So 3% of births, or 3 out of 100 births, vaginal births result in a stage 3 or 4. So not very common, but when they do occur, they certainly do take longer to recover from and can have more lasting impact. All right, so this week, what I would love for you all to do to get the most out of this course is hop onto the Facebook group. If you have trouble getting in there, I've never hosted a private group like this, so I hope you can find it. If you have trouble, just text me and let me know you're having trouble. Additionally, and introduce yourself. What's your name? Where do you live? Where are you in your mothering journey? What brought you to this course? I'd love to know. It will help me kind of curate what I do each week. I will be posting that pelvic floor screening. So go through that, see where you're at. Do you have a lot of yeses? Do you have 1 or 2 yeses? If you want to share your results, feel free. If you want to just private message me your results so I have some knowledge, that's helpful. If you want to keep it private, that's fine too. And then I do encourage you, I will post the YouTube video of how it's not an actual video of anyone performing a vulvar self-assessment. It is me holding up my picture of vulva, but it kind of coaches you through how you would do it. I think that would be great to do this week as well. So that's that. I'm going to end the recording. If you have any questions, let me know. And let's see here. I'm going to stop the share and I'm going to stop the recording. Thank you for joining.